Thank you guys for braving the heat and coming out this evening. So this is part 2 of our MS therapies discussion. Last month we talked about the injectable therapies. Tonight we're going to talk about the pills that are out there. Next month we're going to do the intravenous, the infusible therapies. And then the month after that we're going to talk about what's on the horizon, what's out there from a research standpoint. Before we get started this evening, it was pointed out to me after last month's discussion that I mistakenly referred to Glatopa, which is a glutaramine acetate product. I refer to it as a biosimilar when it is in fact a generic product. So with that, let's see, I think I've got something up on there that doesn't need to be there. So again, we're going to talk about oral options for multiple sclerosis. So just before we get started, how many FDA approved pills are there to change the course of multiple sclerosis? Give me an answer, somebody. So I hear 4. I hear 3. So there's 3. So there's 3 FDA approved medications, and we're going to talk a little bit about all of those. If you can save your questions to the end, we're going to try to keep the questions focused on what we're talking about tonight, but anything's really fair game. So we have 3 FDA-approved pills. The first one of those came out in 2010. The first FDA-approved treatment for multiple sclerosis, Betaseron, came out in 1993. Why did it take so long for us to have a pill for multiple sclerosis? Why weren't the shots that have been around for so long, why weren't those available in an oral form? It wasn't for lack of trying. The injectable medications, Copaxone, Glatopa, the interferon medications, these are proteins, and they're pretty big proteins. And what happens when we put protein into our gut? Our gut breaks it down, chews it up, dissolves it. It's awfully hard to get a protein through the gut to get it to be absorbed into the bloodstream. In 2003, there was a study looking at oral interferon beta-1a. Interferon beta-1a is the same molecule that we see in Rebif, in Avonex, and in Plegridy, and the study showed that it was ineffective in that pill form. Oral Copaxone. So we were very excited years ago because the pill form of Copaxone actually looked like it was effective in the animal model of multiple sclerosis. The animal model of multiple sclerosis is called EAE, experimental allergic encephalomyelitis. We are the only animal that we know of that gets multiple sclerosis. So if we want to study MS in the laboratory, we have to recreate something that looks like MS. The model that they use is typically the mouse. And so the EAE mouse model, the pill of Copaxone worked really well. So there were lots of happy mice out there. The problem was it didn't work in humans. 2 trials. And I can remember when we were part of these studies, there was a lot of excitement that we would have finally an oral medication for multiple sclerosis. Unfortunately, didn't work out. So what do we have right now? Again, the 3 FDA-approved medications are Jelenia, or fingolimod, Biagio, teriflunomide, and Tecfidera, or dimethylfumaric acid. And we're going to start with the Jelenia, or the fingolimod. So this was approved back in 2010. All 3 of these medications are approved for relapsing forms of multiple sclerosis. The dose of Jelenia is a 0.5 milligram once daily. And it was shown to reduce the likelihood of having new attacks or relapses. It was shown to reduce the likelihood of having new lesions on MRI, and it slowed progression of disability. How does it work? It's important to note that when we go across all of the treatments for multiple sclerosis, whether it's injectable medications, oral medications, the IV medications that we're going to talk about next month, all of these drugs work differently. And although they all work, they work differently. And the trick with MS right now is, how do we know for you as an individual which of these treatments is the best treatment for you? It may be that several of them are great treatments. It may be that you're a person who's really only going to respond to 1 or 2 of these drugs. We're still not at a point where we can say that we can consistently pick the right drug with the first try. So there's still some trial and error. Just because you may not get the ideal response to one medication, or you may have side effects that are intolerable with a medication, doesn't mean you couldn't do really well with another medication. So the fancy medical explanation for how Jelenia works is that it's a sphingosine 1-phosphate receptor modulator. What that means is that it locks up inflammatory cells in the lymph nodes. Lymph nodes are where a lot of inflammatory cells process what they're going to do. They present things and decide how your immune system is going to react to it. And as lymphocytes are traveling through those lymph nodes, they get in and out through an active process. And what Jelenia does is it actually doesn't let some of those lymphocytes or inflammatory cells leave the lymph node. It's not killing them, it's not changing the total number of these cells in your body, it's just locking some of them up in the lymph nodes. So what are some of the good things and some of the not good things about Jelenia? Well, one of the good things is it's a once-a-day pill. It's convenient. Some of the not good things is it can have cardiac side effects. These sphingosine 1 receptors are not just present in the lymph nodes. They're present in other parts of our body, including in cardiac tissue. So when we give the first dose of Jelenia, it's possible for the heart rate to drop or cause bradycardia or slowing of the heart rate. There's another side effect called macular edema. This is swelling of the sensitive visual acuity part of the eye, the macula. It's not a common side effect, but we do require that people get a baseline eye examination before they start Jelenia. We also want to have a baseline EKG to know that your heart rate's not too low or that you have some kind of funny electrical problem that would make Jelenia more risky for you. One group that we're very nervous about using Jelenia in would be people with diabetes. Diabetes itself carries some risk of macular edema, so you've already got one strike against you if you have diabetes for macular edema risk. We don't want to put a second strike on board. And so generally, I'm not very excited about putting someone with diabetes on Jelenia. There have been rare cases of PML, progressive multifocal leukoencephalopathy with Jelenia. So we would not want to use Jelenia again in someone with diabetes. We would want to be awfully careful about using it if within the past 6 months you've had a heart attack, if you have unstable angina, if you've had a stroke or a stroke warning sign, a TIA, or if you've been hospitalized for a heart failure within the past 6 months. I think I left heart out there, so it should be heart failure requiring hospitalization. Certain types of EKG abnormalities or heart block, we again wouldn't want to use Jelenia in those individuals. So when you do your first dose of Jelenia, you have something called first dose observation, or FDO. That means when you take your first dose, we want to watch your blood pressure, we want to watch your EKG, we want to watch your heart rate, and typically that means doing that in a cardiologist's office. There are a lot of different ways that we can do this. We have situations where we send you to a cardiologist. There are certain situations where we can actually have the cardiologist come to your house and do your monitoring. They're going to have you take the pill. They're going to watch you for 6 hours doing all of these observations. And then if you have any significant abnormalities, they may actually hospitalize you overnight for 24 hours. It's unusual that we have to do that. Most people go through the 6 hours without any difficulty. So we don't want you to miss doses of Jelenia, but we especially don't want you to miss doses in the first few weeks of being on treatment. If you miss a dose of Jelenia in the first 2 weeks of treatment, you've got to do that first dose observation over again. So there's a big motivation not to miss a dose in the first 2 weeks. If you miss 7 days consecutively in the first 3 or 4 weeks of treatment, we need to do the first dose observation. If you miss 2 weeks of treatment straight, after being on it for 4 weeks, we've got to do the first dose observation again. So this is a drug where we really encourage people to be as regular as possible in taking their medication. Shifting gears, Biagio, the second medication that came out, also a once-a-day pill, came out in 2012, approved for relapsing forms of MS, available in both a 7 and 14 milligram pill, and it was shown to reduce the likelihood of having attacks or relapses, reduce the likelihood of new lesions on MRI, and slowed progression of disability. I wish we had easier ways of explaining how these drugs work. The technical explanation for what Biagio does is that it's a pyrimidine synthesis inhibitor. What that means is if you have inflammatory cells in the immune system, those cells tend to divide and make more of themselves quite quickly. What the Biagio does is it prevents those rapidly dividing cells from making more of those inflammatory cells. So it's not killing anything, it's not knocking the numbers of normal cells down, it's just stopping the rapidly dividing inflammatory cells. So what are some of the precautions that we see with Biagio? When you start this drug, we need to do monthly liver function studies for the first 6 months. After that, we typically do twice yearly blood tests. We typically do some sort of TB testing before you start the drug. This can be a blood test or a skin test to make sure that you've not been exposed to tuberculosis. Some of the other side effects, we've seen GI upset, sometimes some diarrhea or abdominal cramping. One of the side effects that if people read about it, it tends to scare them a little bit is hair thinning. If your hair thins, you are not going to go bald. Your hair may thin. It typically does it at about 90 days, and it usually then reverses itself. Tends to be a little bit more noticeable in my experience in women, and it may be because they are going to hairdressers who are paying more attention to their hair. But again, it is typically reversible. Increases in blood pressure. This tends to be more in people who have pre-existing hypertension in my experience, not in someone just out of the blue, but it is something that needs to be watched. And one of the side effects that we're especially observant for is something called peripheral neuropathy. Peripheral neuropathy is damage in the nerves in the hands or feet. And what it tends to look like is tingling or numbness or buzzing sensations in the hands and feet. What does MS sometimes do to people? It gives you tingling, buzzing, numbness in the extremities. So separating out peripheral neuropathy from pre-existing multiple sclerosis is sometimes a little bit tricky, but it's very important because if we don't take the person off of Biagio and they have peripheral neuropathy, the longer we leave them on it, it may be more likely that they develop permanent nerve injury. Typically with neuropathy, it's like gloves and stockings. So it's both feet and both hands. If you have that and it's brand new, you've never had it before, or you've had it and it clearly is worsening after you start Biagio, let your healthcare provider know. In our practice, we would send you over for a test called nerve conduction studies. These are electrical tests to make sure that there's not any nerve damage that we're seeing. If you do have evidence of that nerve damage, we're going to stop the medication. Biagio should not be used by women who are contemplating pregnancy or men contemplating fathering a child. The FDA is changing the pregnancy categories. Right now we use terms like category B, category C. Most of our MS drugs are category C drugs, meaning that in animal models, if you give really, really high doses, you can see either problems to the mom or to the developing baby. Copaxone and Glatopa are pregnancy category Bs. So most of our drugs fit in there. Biagio is a pregnancy category X. There is felt to be a higher risk to the baby if a mom gets pregnant on this. Interestingly, if a guy is on Biagio and he fathers a child, he can transmit that risk of birth defects to the developing child. So these warnings apply to both men and women. So we recommend that men and women who are on Biagio use an adequate method of contraception while they're on treatment and for 2 years after stopping treatment. Biagio stays in your system for a very, very long time. We're going to talk about ways that we can get rid of it quickly if we need to. For instance, if a woman got pregnant, had an oops pregnancy on the drug, how can we get rid of the medication quickly? Or what if we saw a person who developed a peripheral neuropathy while they're on the medication and we feel like we need to get them off quickly? We'll talk about that. So this is how we get rid of Biagio quickly if we need to. There are two different methods. We can use something called cholestyramine. This is a medication that basically goes in and it helps bind up the Biagio and take it out of your system. It's 11 days worth of the medication taken 3 times daily. Or we can use little capsules of activated charcoal, which also help take the medication out of the system pretty quickly and do that for 11 days. Shifting now to Tecfidera, our third medication, Tecfidera or dimethylfumaric acid. Fumarates, these are molecules that have actually been around for quite a while. A lot of the history of using this type of molecule to treat different health conditions goes back to Germany. Many, many years ago in the 1940s, a German dermatologist who had psoriasis, when he looked at the way psoriasis works, and psoriasis is an autoimmune condition like multiple sclerosis is, he theorized that if he used a certain part of what we call the Krebs cycle, in humans the Krebs cycle is how your body makes energy. He theorized that if he used fumarate or fumaric acid that was part of that Krebs cycle, that he would actually tone down the inflammation that you see with psoriasis. So he came up with these fumaric acids, and the first person he treated was himself, and he found that it worked for his psoriasis. Then that sort of branched out over time into mom and pop pharmacies in Germany making fumaric acids to treat people with psoriasis. A drug company years ago picked up that idea and came up with a molecule called Fumaderm. Fumaderm is a mixture of dimethyl fumaric acid and monomethyl fumaric acid, and it was shown to work very well for psoriasis. Typically used at pretty high doses in Germany to treat psoriasis. So Tecfidera is dimethyl fumaric acid. It's just one of those two compounds. And it's typically used as a 120 milligram twice daily dose for a month or for a week, and then 240 milligrams twice a day by mouth afterwards. Again, approved in 2013. It was the third of our 3 medications. Very important that people take this medication with food. If you take this drug with food, so you may help prevent one of the 2 common side effects. 2 of the side effects that we see, and I'm skipping a little bit ahead here, with Tecfidera are flushing. If any of you have ever taken niacin before, you get there, they talk about the niacin flush, where you suddenly, you kind of look like a lobster. You feel like you're burning up. It's like a hot flash, but just a little bit shorter, but maybe even more intense. What we know with Tecfidera is that if you take it with food, and we mean more than just a glass of water, with like a full meal, you will reduce the likelihood of having that flushing reaction. The other side effect that we see is GI upset. There was a lot of thought that maybe you'll decrease the likelihood of having an upset stomach if you take it with food. Turns out it's really the flushing that you're preventing. This drug was shown to reduce the likelihood of relapses like the other drugs, reduce the likelihood of new MRI lesions, and reduce the progression of disability. Complicated mechanism of action. We were actually very excited about Tecfidera when this drug came out because it looked like it was going to give us a new way of attacking MS, more of what we call a neuroprotective mechanism. So when cells are imaged or damaged in the human body, whether it's skin, muscle, bone, brain and spinal cord and multiple sclerosis, there's a tendency for when one cell is damaged for it to release something called oxidants. And so this cell is damaged, and then because of its damage, it's releasing oxidants, and it influences its neighboring cell to be damaged. And you can kind of have this spreading wave of inflammation and damage. So when we talk about antioxidants, we're talking about things that might help stop that sort of spreading wave of damage. So Tecfidera, you could argue, is a neuroprotective drug by being an antioxidant. It does this through something called the NRF2 pathway. So there was a lot of excitement that this drug gives us something different, a new way of attacking MS that we didn't have before. We talked about a little bit about the flushing and the GI side effects. Those tend to be most prominent during the first 4 weeks of treatment. Sometimes the flushing lingers a little bit. We see people who have been on treatment for years who are still having some of the flushing reactions. The second bullet point, I really can't emphasize enough, and some of this is our personal experience at Shepherd, but we were the largest user of this drug actually in the United States, and we went from being very excited about the drug to being very cautious about this drug. What we learned very quickly is that some people develop lymphopenia. Their lymphocytes, these cells in the immune system, dropped. In the studies with the drug, they saw this in some people. What we saw in the real world was more of it than what we saw in the studies. And we took things a little bit further, and rather than just looking at the lymphocyte counts, we broke it down and we looked at some of the subsets of the lymphocytes. These are called T cell subsets, something called CD4 and CD8 cells. And we saw that in a lot of our patients, these CD4 cells were dropping to very, very low levels. And that was very concerning to us. The CD8 cells also dropped to low levels. We know that low CD4 cells in humans over long periods of time, that's not a good thing. There are a lot of health conditions that are associated with low CD4 cells, including infections and certain cancers that can be seen if those CD4 cells are low. We're not quite as sure about CD8 cells. We don't know if those being low, is that a bad thing? Could it actually be part of the way that Tecfidera works? So that's still being sorted out. What we saw that was especially concerning to us was a small subset of people whose lymphocyte counts were not that low. If we had just stopped there and only looked at the lymphocyte counts, we might not have been overly concerned. But when we looked at their CD4 cells were low, even though the total lymphocyte count wasn't that scary. In the process of us sort of working through this, the first case of PML popped up with Tecfidera. Now there have been several cases of PML associated with Tecfidera. And I think of PML in certain drugs that might compromise your immune system. PML, this brain infection, is sort of like the canary in the coal mine. Once you see PML develop, to me it's a warning that you might see other infections develop. So now as kind of things stand, what we've seen is that it seems like about half of our folks that we put on Tecfidera did beautifully with it. They tolerated the drug well, their MS was under good control, and they did not have any of these issues with their lymphocyte counts. The other half, their lymphocyte counts dropped to very low levels. So there may be people in this room who are on Tecfidera and who are in that good group, who did beautifully with it. We wouldn't take that person off of the drug. We had people who were in the not good group. And so the challenge that we were left with is we've got a drug that is fairly effective, but in our experience had a significant chance of dropping those lymphocyte counts. And our challenge also is that when those lymphocyte counts dropped, they took a long time to come back. Months or even longer to come back. And it made it very challenging to know, okay, now I've compromised your immune system potentially. What drug do I go to now as my next option? So we've become somewhat reluctant to put people on Tecfidera. If you're doing great on it, again, we're leaving you on it. But we've been a little bit nervous because I can't tell at time zero, if I'm thinking about Tecfidera for you, are you going to be in the good group or are you going to be in the bad group? And so we have other treatment options now. Awesome. Thank you guys very much.